Welcome to the lecture on the vasculature and connective tissue of the arm, forearm, and hand. Vascular supply of the arm and forearm. In the arm, the axillary artery becomes the brachial artery after the branches of the circumflex humeral arteries. The brachial artery will branch somewhat posterior and deep to form the deep, also known as profunda, brachial artery. The brachial artery continues on anteriorly into the forearm. Once it passes the elbow and goes into the forearm, it branches into the radial artery and ulnar artery. The ulnar artery further branches into the common interosseous artery, which then branches into the anterior interosseous artery, which runs along the anterior aspect of the interosseous membrane, and the posterior artery, which runs along the posterior aspect of the interosseous membrane. Plate 420 in Netter edition 6 has a good graphic of the vasculature of the arm and forearm. Take this opportunity to pause the lecture to study the vasculature of the arm and forearm in the next two slides from Gray's Anatomy, and then also in your Netter. Vascular supply of the hand. At about the proximal wrist, the radial and ulnar arteries divide into deep and superficial portions. The superficial portion of the radial artery and the superficial palmar portion of the ulnar artery join together, forming the superficial palmar arterial arch. This joining together of the arteries is an example of collateral circulation. Collateral circulation allows blood to get to an area by more than one pathway. This enables better vascularization, whereas if one route is blocked, the tissue will still receive blood from the other route. The superficial palmar arterial arch gives rise to the common palmar digital arteries. The common palmar digital arteries further branch into the proper palmar digital arteries for digits 3, 4, and 5, and half of digit 2. One common palmar digital artery will further divide into the proper palmar digital arteries, which will supply blood to the medial side of one digit and the lateral side of the adjacent digit. The deep branch of the radial artery joins with the deep branch of the ulnar artery to form the deep palmar arterial arch. The deep palmar arterial arch gives rise to the princeps pollicis artery, which is similar to a common palmar digital artery, which then branches into the proper palmar digital arteries for the thumb and the radial side of digit 2. Take this opportunity to pause the lecture to study the vasculature of the hand. You may also want to look at Netter plate 453 for a good diagram of the vasculature of the hand. Use this opportunity to practice drawing the vasculature of the hand. How does your drawing compare? Now that we have completed the nerves and arteries of the upper extremity, see if you can put it all together and trace the blood flow from the heart to the fingertips and the nerves from the spinal cord through the brachial plexus to the muscles and skin of the hand. Now let's move on to learn about the connective tissue investments of the forearm and hand. There will be 5 that we will learn. They include the antebrachial fascia, the retinacula, the palmar aponeurosis, the fibrous digital sheath, and the dorsal hood, also known as the extensor hood. The antebrachial fascia is the connective tissue that encloses the forearm muscles. It acts like a sleeve around the forearm. The antebrachial fascia gives off many septa, or divisions, that enclose each forearm muscle separately. Retinacula are fascial bands at the wrist. We will discuss three retinacula: the extensor retinaculum, the palmar ligament, and the flexor retinaculum. The extensor retinaculum is located on the dorsal side of the wrist and separates the dorsal wrist into 6 compartments. The tendons of the extrinsic posterior forearm muscles pass through the compartments on their way to the hand. The extensor retinaculum is a thickening of the antebrachial fascia. Pause the lecture to study the extensor retinaculum. The palmar carpal ligament is a continuation of the extensor retinaculum on the volar or palmar side of the wrist. It is superficial and proximal to the flexor retinaculum. Do not confuse the palmar carpal ligament with the flexor retinaculum. The flexor retinaculum, also known as the transverse carpal ligament, is on the volar or palmar side of the wrist, deep and distal to the palmar carpal ligament. It is attached medially to the pisiform bone and the hook of the hamate, and laterally to the tubercle of the scaphoid and the volar surface of the trapezium. The flexor retinaculum creates the floor of the tunnel of Guillain between the pisiform and the hook of the hamate carpal bones. The ulnar artery and the ulnar nerve pass through the tunnel of Guillain on their way to the hand. The flexor retinaculum also creates the roof of the carpal tunnel. The carpal tunnel is the space between the carpal bones and the transverse carpal ligament. The carpal tunnel contains 9 tendons and 1 nerve. The nerve is the median nerve. The 9 tendons are as follows: the 4 tendons of the flexor digitorum superficialis, the 4 tendons of the flexor digitorum profundus, and the tendon of flexor pollicis longus. Take this opportunity to study the palmar carpal ligament and the flexor retinaculum, also known as the transverse carpal ligament. Synovial tendon sheaths. The extrinsic tendons of the digits are surrounded by bursae to reduce friction. These structures are called synovial tendon sheaths. The palmar aponeurosis is a thick fan-shaped fascia in the center of the palm. It functions to hold down the tendons and also to protect the soft tissue structures of the palm. The fibrous digital sheath is the connective tissue that overlies the tendons, which are surrounded by the synovial-filled synovial tendon sheaths. The fibrous digital sheath holds down the tendons of the long finger flexors, the flexor digitorum superficialis and the flexor digitorum profundus. The fibrous digital sheath contains 8 to 9 pulleys, which attach to the volar plates of the palmar aspect of the digits. The purpose of these pulley systems is to prevent bowing of the flexor tendons or lateral shift of the flexor tendons during contraction. There are 5 annular pulleys which wrap horizontally around the synovial tendon sheath. Their job is to impart strength. There are 3 to 4 cruciate pulleys, depending upon your resource, and these are in a X-shaped form that impart flexibility. Pause to study this great slide, which actually depicts not only the fibrous digital sheath, but also the tendons, the nerves, and the vasculature. Take time to pause the lecture to go ahead and draw a digit from the lateral view, including the fibrous digital sheath with its 5 annular pulleys and its 4 cruciate pulleys, as well as the volar plates. Note the volar plates span over the metacarpal phalangeal and interphalangeal joints. The dorsal hood, also known as the extensor hood, is a connective tissue expansion of the extensor digitorum tendon. It is located at the level of the metacarpal phalangeal joints and proximal phalanges of all 5 digits. The dorsal hood serves as an attachment site for several mid-palmar muscles which we have discussed previously. The extensor hood has oblique fibers, transverse fibers, and a sagittal band. The sagittal band serves to stabilize the extensor tendon and helps to maintain the central position of the extensor tendon. Pause the lecture to study the anatomy of the dorsal hood, including the oblique fibers, the transverse fibers, and the sagittal band. Also be sure to note the attachment sites for the mid-palmar muscles. Another good resource for studying the dorsal hood is Netter, Edition 6, Plate 451. These are 2 links that are also good resources for studying the dorsal hood. Now we are going to cover a few connective tissue pathologies of the hand. The first being carpal tunnel syndrome. Carpal tunnel syndrome is often due to overuse or poor mechanics of the hand. The carpal tunnel itself has limited space due to the bony base of the tunnel and the thick transverse carpal ligament on the roof. Thus, anything that causes swelling or enlargement of the tendons overuse can create compressive forces on these structures. The median nerve also passes through the carpal tunnel, and so if there's any increased pressure or swelling, the median nerve can be compressed, causing numbness, tingling, and also paralysis of most of the intrinsic thumb muscles. Bren's contracture is a progressive shortening and thickening of the palmar fascia and aponeurosis. This contracture most often causes the ring finger and or other fingers to pull into flexion at the metaphalangeal joint and proximal interphalangeal joints. 50% of the time it is bilateral. It is most common in men greater than 50 years old. The cause is unknown, but there is some thought that it may be genetic. Treatment for this contracture involves excision of the fibrotic tissue. Boutonniere deformity is most often associated with rheumatoid arthritis and is the disruption of the central slip of the extensor digitorum. It may also be due to laceration or rupture of the central tendon or the proximal interphalangeal joint dislocation. Boutonniere deformity is described as metacarpal phalangeal joint extension, proximal interphalangeal joint flexion, and distal interphalangeal joint hyperextension.